So what is in My Health Record? So it's a summary. Now this is some of the information that people sort of think it's all of their records. It's really only a summary of their health records. And I'll show you what's in a shared health summary. It's just an immunisation, allergies, medications and past medical history. How many people here are actually uploading? Oh, 3? That's great. And how many of you are all getting the EPIP? Everybody. Good. So you're all registered. Do you think you're getting the EPIP? Probably. Did you? Yeah. Anyway, we'll go through that. And it's a national system, so obviously it's better if it's national, because if people are holidaying or whatever, wherever you go, people can see who's Jane. I introduced myself, Jane. That's all right. It's personally controlled, and one of the things about personally controlled is people, some of your doctors or yourselves will be saying, well, what's the point of it if patients can hide or delete records? Yeah? You've all been hearing this? Okay. There is, I think, oh, John, you'll be able to tell me, there's very few records that have been deleted, and most of those that have been deleted have been by healthcare providers because they've made a mistake, deleted it and uploaded another record. There's less than 0.03 of the population that has a record that have access controls on their records. And a lot of people don't use those, but they want to know that they can control their record. And that's one of the reasons they would put a control on there, is they just feel it needs to be controlled. It can be viewed anytime, anywhere by any registered healthcare provider. Now, I'll go into that a bit more, because that sounds like anyone who's got an HPII can view a record. I'm a registered nurse. I've got an HPII, but I'm not attached to an HPIO. So there's under no circumstance could I hop onto the portal and view anyone's records. But we'll go into that a bit more. And most people, all of you here who are working in practices, if you've got conformance software like Best Practice, Medical Director, Genie, ZMed, they're all conformant to the national system. So it just goes through there. Your practices, you and your doctors don't need an individual NASH certificate, because you don't really need to go onto the provider portal. But if you've got allied health workers who are working in an isolated area and don't have clinical information systems, and they only have their internet that they're working through, as long as they've got an HPIO and can get an HPII, of which I'll talk about in a minute in a bit more depth, they can have a look at the provider portal for their patients' records. They cannot upload, but they can view. So, what is in each of these things? So, for the patient, the medications and allergy summary, this is called the patient health summary, and it can be viewed by the provider. So, this will come up in the document list, which I'll show you shortly, if a patient has uploaded this. So this is if somebody has some allergies and they haven't gone to their doctor, the doctor's not uploading information and they're travelling, they might want to put this in their record. So they go somewhere and people will see that they've got an allergy and medications. Health professionals will view it. They should just ask about it. They're not going to take it for gospel, the same as when patients tell them stuff, they check up on stuff. Personal health notes. This is where the patients might keep a record of their blood sugars, for example, and or something like that. So it's in their record, but it's not viewed by providers. Child development information. I think that's only in New South Wales. That one. You can measure your head circumference and all those sort of things. Advanced Care Directive custodial contact details. This has been here all the time. This is quite well used. There's a lot of people with those. We'll see the data in a minute. And what's new is the Advanced Care Plan. Now, this is where patients can put their advanced care plan up into the record, and it will be viewed in the document list by the provider. If any of your patients want to do it, there's some good instructions on the My Health Record website, and it steps the patients through how to do it. Some patients will take this to their doctors because the doctors will have discussed this with them, probably signed it with them. Each state has a slightly different document that they might want to upload. So the doctor's surgeries, you might be asked to upload it for the patient because you need to scan it into their record. It's the patient record. It's not coming from you or the medical officer. So that's really clear. It's the patient information, but you might want to help them upload it. The health professionals can put up a shared health summary. We've targeted GP land with a shared health summary because this is the key information people need to know about a patient if they're going to another provider. And because their home is the GP, we were hoping we'd have millions up there by now, but maybe we will by this time next year. So that's the shared health summary, and I'll show you how that can be uploaded. An event summary is just for a significant event, or if you're going to a doctor that's not your home doctor or your main care provider. So if I was on holidays and I cut my foot on oyster shells or something and I got a tetanus shot, it would be a good idea to put an event summary up so my home doctor would know I've had an immunisation. Allied health professionals will be using this event summary because they don't put up shared health summaries. So the only people who can put up shared health summaries are medical officers, registered nurses or Aboriginal health professionals, health practitioners, they're the ones that are registered with APRA. So that's a big incentive for a lot of Aboriginal health workers to get their Cert 4 and get registered so they can then upload a shared health summary for their patients. So if any of you are working in Aboriginal health, you might sort of push them along that way. Discharges coming from hospitals. Now, there's plenty of hospitals uploading discharge summaries. Even in Victoria, they're starting, which is fantastic. They've been a bit slow down here. But Kids went live last week. Frankston went live last week, as did Peninsula. So you're getting quite a few different hospitals. We're working with Monash. They'll be going live pretty soon. And Melbourne Health's going live soonish, not next week. But so all of Queensland, all of New South Wales public hospitals are uploading discharges. WA has got a few hospitals. We've been doing a lot of work down in Albany. They're uploading. Royal Perth, Fiona Stanley, Women's and Kids, I think. Yeah. And all of Northern Territory, all of Tassie and all of ACT. So across the country we're getting a lot of discharges. So that's very useful for you in your practices. You don't have to ring hospitals, you don't have to chase things. And there's a very good video, which I'm not going to show you, about a doctor in Adelaide who got a patient back from a Sydney hospital, told to see their GP for follow-up, nothing else. And of course it was all on there. Saved him over half an hour. E-referral and specialist letters. E-referrals are pretty slow. Specialist letters are coming up from the Northern Territory Hospital, one of the hospitals there, and also St Vincent's in Sydney. Prescription and dispense is going well, and so if you've got pharmacies next door to your practices, which many of you do, find out what software they've got, and if they've got Fred or Simple Aquarius, get them to get registered and get going, because then in your practice you'll be able to see the dispense records with the prescription. So think about that. Diagnostic imaging and pathology reports is not, it's available in the system, but nobody's hooked up to it yet, except the Northern Territory public are sending lots of DI reports. Medicare, I'm not going to go through those, but a lot of nurses find it really, really useful to look at the immunisation register through My Health Record, because it's much easier to see a patient's immunisation records through there than ASA. You'll all agree, those of you that are doing it? Yep. Okay. That's what we just did. Privacy. This is one of the things that we get asked all the time about the privacy. So the information, because when you register now you don't need to sign the participation agreement, but so there's some different penalties that have come into play as a result, and this was, you've seen it in the press where doctors will be fined $180,000 and go to jail or something if they look at someone's record by mistake. That's not the situation. It has to be a malicious intent, and some of you, you know, your South Australian case where they were able to audit everybody who looked at the wrong records. Same's happened in a Sydney hospital. So there's a much better way of seeing who's looking at what. So there's that system of audit. So it is only misuse. So if somebody was to look at your record and sell it or something like that, there would be severe penalties. Individuals can set access controls and also choose to be notified. Some people have got an SMS every time someone looks at their record, others get an email, but everyone can go on your How many of you have actually got your own health record? Go and have a look and you'll be able to see the audit of who's looked at your record when. And just bear in mind, sometimes the high street medical centre has got a different name to what you think it has. So it might be your proper doctor. You know, they're registered for tax purposes under something else or ownership or something, you know. So just be conscious of that. System security, it's as secure as it can be. It's got bank security, strong encryption. As you know, that's why it's difficult for for patients to log on. You need all those different things to ensure that it is secure. You can link it to if you've got a MyGov account, it's quite easy to link My Health Record to. You can just go down and link it. You can do it here on our stand if you wish, today or tomorrow. And so it's the MyGov portal. And to date, there's no identified instance. John will tell me that there may be some unidentified ones, but I don't think so, is there? So you can rest assured, and it has been in place, and I'm sure people... And one of the biggest things is people are suggesting that the Russians or the Chinese might want your identity. But I don't think they do. Provider liability, there's no change. And the thing, when you're talking to your doctors or anyone else who's a bit sceptical of this, or yourselves, there's nothing that changes in what you're currently doing. You expect the practice to meet all of the privacy requirements that are in your standards, all of the security standards, and have passwords, not share them. All of those standards that you know you need to meet for accreditation. This is no different. This isn't adding anything else. All this is doing is giving you the availability to actually have more information than what you've currently got if your patient goes somewhere else. So it's not really extra. The thing that this will do is sometimes highlights stuff that's already happening in the practices, and it's highlighting safety issues or something else, and that's when people get a bit anxious. But there's no change to existing requirements that should be being done for your accreditation processes. Okay, so where are we at? We've got over 2.7 consumers registered. This is at the end of April. Obviously, when the opt-out sites happen, we'll have another 1 million or so. The issue is general practices, 5,300. Now, what's happened to those, because the summary, there's only 95,000 shared health summaries, so I bet they're not all uploading shared health summaries. Now, one of the things, if you go back and get started in your practices, all your certificates will have expired. So that's a huge headache for you and your practice managers. You don't have to do it, but you might want to talk to your practice managers about how to do that. And we've got some support on the website, but just think about that. So there's 508 public hospitals. Now there's 38 private hospitals. All of the HealthScope hospitals are in the process of getting connected. Ramsay's are working towards getting connected, so there's something like 43 or something HealthScope and 70 odd Ramsay's. The Epworth is connected, and there's quite a few private hospitals around the place. So, you know, it's happening, and you will be getting, from those private, you get an event summary when someone goes to hospital, and then you get a discharge when they leave. It's a nursing discharge, but it tells you what you need to know about that patient while they're in hospital. Retail pharmacies, these people aren't actually sending up stuff. So a lot of pharmacies might have been registered, but they don't have the correct software, or the software's not connected. So just check with your pharmacies if you're nearby, because as you know, one of the biggest benefits for this is your medications. So you've got to get your dispense records going up. So we need to start targeting pharmacies to get going with uploading. It's an automatic process for them. As they're sending their ETP to their PES, it'll be automatically uploaded if the patients are registered. So it's not an extra workflow for the pharmacies. So all they need to do is get registered and make sure they've got conformance software. Okay, and just if you're interested, this is the wrong slide, but see the age here, 40% are age 20 or less. Most of those are in 0 to 4. Because as kids have been born for the last 4 years, and they get their Medicare registrations, they're getting their My Health Record at the same time. So if any of you are working with lots of kids, they're bound to be registered. Babies, you know, under 4. Well, they tick the box, they must do. It's not automatic, they have to tick it. What are you looking like that for? Yeah, well, start looking for their immunisations, because if you're treating the kids in the software, it'll come up with a green button if they're registered, and so if you see any green buttons or green writing in Medical Director, you can then go on and look at their immunisations through their Medicare data. So you will start to see them if you are looking, you're immunising kids and stuff. So this slide here, this is one of the important ones, I think. Because this is about how this is the underpinning infrastructure of the My Health record. So you've got the organisation, HPIO. Now, the only people who can get an HPIO, they have to be delivering healthcare. So if you're an insurance company, you're not going to get an HPIO. So if people talk about, what if people, like the income protection people, will see my record? Well, I don't know many income protection people who are delivering healthcare. So they won't be seeing your record. So what happens is an HPII, all of you here who are registered nurses will have an HPII, and you get that from APRA, or you can ring DHS and get it, or it's on your re-registration letter. I think there's you get it there. And when you're working in the practice, you're hooked to the I is linked to the O with your security. That's your your NASH is your security. So that's how it all links together. And then you give the care to the individual person. So that's how it works. So, as I said, I've got an HPII, but I'm not linked to anywhere, so it's useless to me until if I was to go and work in a practice, they'd link me to the O, and then I could practice. I could deliver care and look at people's records. Now, for an allied health person, say, who's a sole practitioner, they're still going to have to get an O and a I before they can look at the portal. So, and say you've got several doctors working at different places, every place they go to, their I will be linked to a different O. So if they went onto the portal, for example, it would have a list of the O's that they're registered with, and then they could click one of those. So just people are a bit confused thinking that your doctor can go home and look at everyone's records on the portal if they've got an individual NASH certificate. Absolutely not the case. And if your doctor and your GP is going down to a pre-employment clinic, the pre-employment clinic probably won't have an O, because they're not giving health care, they're just checking out people. So he won't be able to see people's records down in that clinic. So that's just one of the biggest worries we get at community groups that doctors keep asking us about. So this is the security of linking. That's how it all works. And that's the infrastructure behind everything. So it's an important thing to remember. Now, I stole this from, I have referenced it, it's a PwC document. I think this is really, I like this because this sort of talks about what we're all trying to do at the moment in chronic disease management, in your primary care. You know, it's network clinicians, multidisciplinary care, good clinical governance, you know, integrated care planning, all of these things, care management, complex needs. And you've got, this is all of you healthcare providers around here. And then you've got your patients here. You have to be networked to be able to do this. I mean, this is a pretty complicated diagram, but you're all trying to do it with all of your patients, you know, much more, even all the, you know, your nurse-led clinics, all of those things. You're going to have these communications. So we've got to start somewhere. And that's what we're starting now with the My Health record. You know, you might think it's a bit basic, there's not much information in there, but if you don't start putting information in there, we're never going to get to this. So, you know, we've just got to get going. And really, it's here to stay. And let's hope within a year or two, we can look at this and say, yep, we've got all the pharmacies on, we've got all the GPs, nursing homes, hospices, community, etc. You know, and we've got some of them now. Some of them have got documents. So, you know, go back home, get your certificates sorted and start uploading. Okay. How does it benefit you? You know this stuff, don't you? Better access to health information that you don't already have. So you're going to know if someone's been into hospital. You know, the patient may not come to you all the time. They may go to another clinic. They come to you because they're on holidays and they've just been to hospital. You'll be able to see their discharge. You'll see what drugs they're on. Improved continuity of care, timely access, clinical handover. The patient doesn't have to remember everything. You know, how many of you have been in an emergency at 2 a.m. in the morning in a busy hospital emergency department? Honestly, it's a nightmare. People have got bags of drugs. Someone rings their patients at 1 a.m. to find out what they had done a couple of years ago. Honestly, all GPs who have forgotten what it's like should pop in there just to remember. It would save the time. I think we could get patients through there in half the time because, you know, ED physicians they spend quite a lot of time doing a good assessment. You know, they have to, and then they work out a plan of care. So if they've got this, they just have to validate. Informed decisions on medical needs. It saves time in your practices. You can do other stuff. You're not going to be able to reduce your staff unless you want to, but you can do other stuff like talking to the patient, caring for them, making a better care plan. Reduce the volume of paper documents, reduce time scanning. I think aren't we keeping the faxes alive in health? What other industry faxes as much as we do? Huh? Really? There was a story, I was working with a couple of the people from health and we were in Ipswich the other day and I was already at the PHN and the two fellas had got off the train and they were walking along and someone was walking beside them and they had some x-rays and they said they were just chatting away and this guy had gone to pick up his x-rays 3 times and they hadn't been ready and he was limping, so he obviously had a sore leg, so he'd gone up to pick them up, no, not ready, gone up 3 times because he had a doctor's appointment at 4 o'clock. This day and age should definitely be electronic. I mean, would you let your bank do that? Anyway, so what's in it for individuals? Improved coordination of care and not having to repeat their story. I mean, how many times do you fill out those forms every time you go and see somebody? So some of that will be not happening. Reduced duplication of medical tests. How many people, get pathology taken time and time again because they haven't got a copy of it? And the patients are at the centre of the healthcare. Many of you live in holiday regions, so you've got a floating population. You know, especially in Victoria, everyone escapes the cold and goes up north. You've got 2 GPs, a summer and a winter GP. How does that work? You know, and that's very common. Like Tweed Heads, you know, I used to live up around there. Half the population was there. You know, the hospital would double in patients, and they're all Victorians. All right. Now, I'm going to see if this works. This is a nice little video. It's not Chris Moy. Let's see.
My name's Kelly and my son is Henry. He's 11 and a half weeks old. I've been coming to this practice since I was about 8 years old, so about 29 years that would be. I've got an autoimmune disease called lupus, and that requires a bit of ongoing management. I hadn't heard about my health record till Dr. Maker told me about it, and it was actually surprisingly easy. I thought it would be hard, but I logged in to the website and it probably only took about 5 or 10 minutes, and yeah, it was easy. It doesn't cost anything and it hardly takes any time to set up, so why wouldn't you?
My health record came up with Kelly when she had a new baby, and I suggested that it would be great if she and Henry opened a record because Kelly has chronic conditions, and I think having a number of different healthcare providers that have input into her care, it's really empowering for her, in my opinion, to be able to have control of what goes into her own personal health record and for her to be able to share that with people in the future.
I need to see a rheumatologist regularly, and she'll often refer me to another specialist. I've also had to see on and off a psychologist. It's there for the GP to see without me having to carry around files and things like that. It's all in one central place. I've signed Henry up for it, and from birth all his records are going to be there, so by the time he's 18 he's going to have his full medical history. I find myself thinking a lot more about my health and what I can do to make sure I stay healthy, because it's suddenly a lot more important than it used to be, because you can't prevent sickness happening, but you can do your best to minimise its impact. So I've got to stay on top of my health for his sake.
Okay, so that's available for you to put on your practice media if you wish. There's two of them on the website. So, okay, does anyone have any questions? We might just sort of have a few questions and then I'll keep going. I'm going to repeat the question so that, because we're being recorded.
Scenario really. It's like the parent takes the child to hospital, and again it's 2 a.m. and then they get discharged, and the hospital says yes, we'll send everything to your doctor, and the patient goes back, and nobody at the hospital asks, has your child got an e-health record? So the patient goes back to the doctor and says, okay, it's all done. They said they'd send it to you, and the GP doesn't realise that the patient has an e-health record either.
Yeah, the GP will know. Did everyone... The question was, how does the hospital and the GP know about who has a record? The GP systems go green if somebody's registered. So, and I'll show you some of the software shortly. The hospitals have a viewer, and so each hospital has implemented things differently, but it's the same thing. They'll go that you'll be able to know if they've got a record in the system. It's about educating hospital staff to look now. And in New South Wales, discharges are going from the emergency department as well as the wards, whereas in Queensland they're only going from the wards. So everybody's done something slightly differently, implemented across the jurisdictions. So does that sort of answer your questions? And in New South Wales, the discharge, what happens in these hospitals, the discharges go up for everybody, and those that have got a record, it goes into the system, the others it just disappears, it doesn't go anywhere. That's right, isn't it, John? Yeah. That was a question back. Okay, in the software, there's a My Health record. It's called PCHR. The software hasn't changed it to My Health record yet. It's a button that says there, and it'll be green. No, it may not go green, and best practice doesn't always go green either, because there's a bit of an issue with best practice, which will be changing when they do their new version. Best practice have got a new version that they're in beta testing at the moment, and they've got a lot of changes, so the beta testing is taking quite a long time. Good question. Emergency services currently don't, but we're working with them to work out a way so they'd be like allied health. So what happens with allied health providers, those that are registered with APRA get an HPII automatically. Those who aren't, like the speechies and the social workers and the dietitians and those sort of people, they can get an HPII if they belong to their association. So every year they need to give evidence that they're still belonging to their association. And that's a problem in some of the areas up in, like the Kimberley, for example. They think, some of the people who might work up there think it's not worth belonging to their association, so they don't want to waste $300 a year. They won't be able to upload, and then it's up to the organisation how they enable them to view. The ENs are registered with APRA and they can get an HPII. They can't upload a shared health summary, but they can upload an event summary. Although they're registered nurses to some degree. So I think it's a bit, depends how you use them, but technically they shouldn't. Yes. The question is it automatic with the pharmacist? When does it go up? So with the pharmacist, when they send the script, if they're dispensing into the ETP, so it goes off to say ERX, yeah, you're still with me? It'll then go, if they register, it'll go straight up to the system. Yes, there's a view. There's we'll have a look on the what it looks like. Yes, as long as you know that pharmacy's connected and able to do it. Because there's several pharmacies using different software that aren't connected, so you just need to make sure they're either using Fred or Simple Aquarius and they are connected. So that's what you need to start checking on, pushing for it. Just a couple more questions and then we'll... well, the public systems, we're working with the jurisdictions, and hopefully Queensland, New South Wales will be, and John might be able to assist me here, but we're looking at about December for them, I think, a bit later, and then we're working with the private providers to upload, and that's looking about a year away. So it is working, and there's some work happening here down with Monash to look at the DI, because at the moment with the diagnostic imaging, only the reports are going in. We can't put the images in, but we're looking to see if having a URL link to the repository that's down here already, how will that work? And so that'll be a little pilot, a sort of work in progress. And if that works, that'll be really helpful because people want to see the image, and most of the states have got statewide repositories. The after-hours doctors, well, there's so many of them, but a lot of them are using best practice, unfortunately, and there's no event summaries. In best practice's next version will have event summaries, because your after-hours, and that's absolutely a good point, should be uploading an event summary for everyone they go to, and that's what we're hoping will happen. Oh, well, they should. If they're registered, they should be able to view it. And if they're using their laptops, they can view through their home system. It's when they use the mobile technology, like their iPads or their mobile phones, they can't view because there's a security issue. That's being worked on. There's a mobile strategy occurring, but it's not ready yet. And I'm thinking that'll be between June and December. There'll be something happening. No promises. Oh, yes, there are. South Australia was one of the first states to go live with their discharges, but wherever they rolled EPAS, of course, it broke the system. But there are still some hospitals, as you know, that haven't got EPAS. They are sending discharges, and I think I had a look last month, and there's about 1,000 a month going up. So you've got some patients registered there. So the thing is to get more patients registered and get them starting to get their discharges in the system. Oh, no, event summaries. I'll show you how what you do is you view it on the document list. We'll go to that. No, download it automatically, no. Yeah. Yeah. Here, John. John? Wait, hang on. You're being recorded.
Very careful what I say then.
Exactly. Only tell the truth.
To have a My Health record, you don't have to have a MyGov account. If you want to create your record yourself and you're going to...
Eat this mic, John.
Testing. Okay. To create a record for yourself, the way you do that online is to go through MyGov. But many people get records created through assisted registration in a GP practice or in hospitals. So you don't have to have a MyGov account to have an eHealth record, or have a My Health record. But those that have created a record themselves online will do it. That's the only way you can create it yourself online. If you use a Medicare channel, assisted registration or something, you can certainly have a record without having a MyGov account.
But if you want to view it...
If you want to access your own record, you absolutely have to use MyGov. Right. Yep.
Yeah, so you have to go in. But if you've got your elderly people who relatives aren't going to be their nominated reps or authorised reps, and they don't care, they're never going to look at it, just register them in the practice, and that's all they need to know. Because they don't necessarily want to look at it, they just want their providers to know what they're on and stuff. One more question, then I'll keep going. Yeah, you can. Yeah. Well, the regulations say that you should be a registered nurse or a registered medical practitioner or a she for shared health summary. You can still do it. You don't block it. It's not blocked because we don't look at what the HPII signifies. But if you're using her for care planning and uploading shared health summaries, that's perfectly okay because she's part of a nominated care team, so that's all right. Okay, the Northern Territory, I'm not sure if anyone's here from the Northern Territory, but they've been using their My EHR for 10 years, and it's predominantly been in the Indigenous population, but we evaluated it, and the evaluation report is on our website. And these were the two lessons really out of it. So it's a gradual evolution towards a critical mass. So you've just got to start somewhere and get some critical mass. And that's what I was talking about before with the coordinated care. And becoming embedded and routine into administrative and clinical workflow. So the new versions of Best Practice and ZMed are going to have prompts. So if you change something in a patient's record, like medications, for example. So someone's been on blood pressure pills and they come back in and they have different medications and you start them on a diuretic. A prompt will come up saying, you've changed something significant in this patient's record, do you want to upload a shared health summary? Press yes and up it'll go. So that's what'll happen. And for your EPIP, it doesn't matter if you've got two records for the same person, providing, obviously you've changed some care or some significant part of their treatment, it's still counting as one. So it's not patients. You don't have to have 5 patients that might be the same person who's your chronic disease patient. So these are just some things that people started to say. This came out, and one of the things that did happen in the Northern Territory, once the nurses started using it and embracing it, it was much better adoption. But it was getting patients, their consent was sort of based on a community rather than individual, I think, in a lot of ways. So, it was a bit easier to get patients. And these are just some things, that you can get a copy of these slides. But PHNs we're doing a lot of work with PHNs, sending out lots of information to them. So if you've got a local PHN, embrace them, use them, pick their brains. I see a couple of staff from PHNs here. They'd be happy to share their information and their knowledge. So they can be your first port of call. The Department of Health, Sheldon and Karen are sending out lots of information all of the time to keep them up to date. They're doing lots of training. I've been with a couple sometimes to community forums. So people are coming together because people want to know about EPIP at the moment, so your PHN will be helping you and supporting you. So we've got this helpline support. PHNs will help you, but there is not one helpline, unfortunately. We'll work towards that in the next year or so. So a lot of your inquiries might be about DHS issues. So anything to do with HI and certificates are probably belonging to DHS. NEHTA's got a help centre which will, and the people there will point you in the right direction. They're pretty good at triaging. They've also got a whole lot of error messages. So if people get an error message, ring up NEHTA and say, what's this mean? We've got about, the top 70 or some such thing that they can look up for you and tell you what it is. We're doing just a bit of a plug. We're doing a webinar next Thursday for anyone on how to get your certificates up to date, and then assisting patients to register. Okay, so this is the My Health Record website, and it's got a lot of stuff on it. So I can just show you what's on here when you go to the health providers. So you've got all these things here that you can go and have a look at, and they're pointing you into different directions. So there is a lot of information. I think our tools and collateral have really improved over the last year. So there's a lot of information. I won't go into that too much. Okay, the NEHTA website, you can do all this stuff, but we've got this, one of the things here, I'm a bit worried about our internet here working. So what we've got is software demonstrations. And one of the things that I want to talk to you about is providing assisted registration. Because in the practices, you can get your patients registered. So we've got it for these software here. There's these pamphlets that are out now, and you can get them from either us or the Department of Health. And what I would strongly recommend is putting these in your waiting rooms by the hundreds and putting the form that you no longer need to be signed in with them. So then the patients can read this, fill out the forms, sign them, give them to your reception staff. Because your reception staff are probably a bit anxious about selling this in case they get questions they don't know the answer to. So instead of setting them up initially and saying, we're registering today, ask me, do this sort of thing, have it in the waiting rooms, and then if they've got a question, either you can help them or the practice manager can help them or someone else can help them. The reception staff will get used to helping them, but they don't sort of ask them straight away. And this is pretty self-explanatory about what the benefits are, and all their issues will be addressed. And there's lots of practices starting to do that, and then the reception staff only have to do a couple of things. So say we've got, to fill it in, I'll show you what's in Medical Director. There's this up here, you can see where my arrow is, download summary sheet. So this hasn't been updated to say you no longer need to, so we've got this cheat sheet of how to register. So if you look at this, it says, see this icon here. This is on the information at the front office. So it's a different icon to the clinical system in Medical Director. And so your reception staff can register people without going into the clinical system. And then you just log on. They need the permissions, but your practice manager will know all that stuff. And then this is all you need to do. So this is the form you need to fill out. So this all gets sucked up out of the system once you've put it in there. If they're a new patient, you still got to do all this stuff in the system that the front staff does. And here, if this IVC is just the code that the patient takes to log on themselves to create their record at home. And often, if you just send it through to the provider, you can print it out on a piece of paper and give it to them. In best practice, you can print that out when it comes back. So then here, it's just all the Medicare information. So some people don't care about looking at their PBS and MBS. Don't tick it. If they're interested in it, they can look at the last 2 years. And then here, more often than not, it's been attending 3 or more times. So they don't need any identification. You just need to put that. Now here, application form ticked. Now a medical director won't go anywhere if you haven't ticked that. So talk to your practice managers and suggest that you write a policy to say you're going to tick that to say that you've got consent from the patient. Yes. Yeah, I think so. It's an under 14, isn't it? If they're under 14, they're attached to their parents anyway. Yeah, that's right. Yep. So tick this and write in your policy somewhere that you're still ticking this, even though you've not got a form. So then that covers everybody who gets anxious about doing this. And then you just submit it, which is my next screen. And that's it. So, and then you'll get the code and it tells you. So you just press one button and that's it. Now for receptionists doing that, that's actually quicker than doing a Medicare claim. And so once you get into the habit of just getting people to, if they don't have to talk to them too much, they'll be very happy to do this. So that's the secret to get your chronic disease patients through the practice. I can't stress enough how important it is to get patients registered. Unfortunately, we're not in an opt-out world just yet.
So we don't need to keep copies of this in?
No, you don't need to keep those forms. The policy, you would say we had informed consent, because if they've signed it, clearly they are happy with reading this and they think they're informed enough to sign a consent form. So you can say the patient's had informed consent. So that may be with a conversation as well. And then you can just, that's it. Yeah, it was just that someone brought up the fact that it doesn't work if you don't tick that, because you technically haven't got that form and you're not scanning it. But if you've got a policy around it, and all the software will start to change that, but they haven't yet in this next version. So it's just sort of making do until the software catches up. So that's the software demo. And you can print this out and put it beside someone's desk. The same is for... Robin's got some at the back. Yeah, they're on our website, aren't they, Robin? Yeah. All right, so that's a software demonstration for that. So use the software demonstrations if you want to and print those out. Put them beside you when you're doing your care planning process, because you might forget which button to press. And you don't want the patient to think you're silly, you know, because you can just have a little look and think, oh, there it is. So let's just go back to the NEHTA website. So then we've got this sandpit, which is fantastic, if it works. So this is on-demand training. And so the password here, which tells you earlier what it is. It's trained me with no space. Now I know for a fact medical director and best practice aren't working, so I'm not even going to go on there. So these are the software. So is there anyone that's not using one of those? You could go to the demonstrations. So these are the main ones. So what I'm going to do is just have a look at Jeannie, I think. So this is good for your doctors to have a play. It's good for yourselves to have a play. So go on. If any of you ever get an error message, can you please straight away send it to the help centre? Because if there's any problems, we want to be able to fix them straight away. Just this afternoon. Did it work this morning? No. Okay. No, it wasn't you. It was our system. So they're working with the provider. So this is Jeannie. Have we got any Jeannie users? Fantastic. I was going to use Communicare, but I think Jeannie's nicer. Not a sales plug there. It's just the way they've put things. So what you're going to see in Jeannie is very similar to what I'm going to show you is how to upload a shared health summary. So the doctor, the password is password, P, the @ WS0RD. But it tells you down the side here how to do everything. So this comes up for all of the software, so you can just go through each of the instructions. And the patient's name is Derrington. Caleb. Okay, so in Jeannie, how they've done, so everyone's done it slightly differently. They've got this PCHR button here that you actually have to press on for some reason. That's how they've done it. So when you press on it, it goes to check the IHI of the patient and brings that back or validates it. And then it goes red, orange, and if you click on it again, it goes and does PCHR exist. And then it tells you they've gained access to their record. Now, the others, medical director does it automatically in the background, and you don't have to do any of this stuff. It just happens. And you see how this button's green? That's exactly what it looks like in most of the software, one way or another. All right, so I'm sorry I can't show you the others, but you can get a sense of there. And what happens when you click that, a PCHR button comes up here in Jeannie. All right, so it wasn't there before. So when you've got Jeannie, for example, start clicking on this button to see how you go. It's not the best, most usable way, but we're getting there. So when you click on this button, and then you say View Document List. So now we're going into the patient's My Health record. This is exactly what you'd see in most of the software. So we're in the record now, and it's just a variety of how people have done it. So we've got a date, service date because it's a discharge, so the dates might be different when it was written and when they were actually there. That's what that means. What document it is. So you've got a list here. So if the patient had their own, this is where you'd see advanced care plan, and this is also where you'd see the patient's personal care record or something. And so where it's come from and what type, which is wrong because the discharge would have come from a hospital. So that's just in our problem. That's our, when we're in we're not actually in the system, we're in a practice one.
Can you transfer the specialists that are from there into correspondence in?
Yes, but I'm not 100% sure how to do it in Genie. And, yeah, and well, you can see down here, in the others down here in both medical director and best practice has saved to patient's record. So you open it up and you save it, and it goes into both of them. I think go into correspondence in, and there's a in their progress notes it says discharge downloaded. So it's recorded a couple of times. So what I'm going to do, so this is the patient's record. So here it says send a shared health summary. So this is exactly what happens in all the other software. So now it's pulled it out of the clinical information system. How quick was that? I didn't have to type anything. I didn't have to do anything. So people imagine you've got to type all this stuff. So what has happened is it's pulled it out of the clinical information system. This happens in both best practice, medical director, ZMed, all of those others do exactly the same. So they're the 4 boxes and they're all ticked. So the only time now is unticking irrelevant and old data. So this is where your dirty data is, here. So if I've got things like eye test for driver's licence, you don't need that. If you've got hypertension written 25 times, you don't need that. So this is where it's going to take the time for you and your doctors to upload. So this is about making sure data's coded and all that sort of stuff. Now in best practice, they actually have a column which says upload to PCHR. So if you've got someone else cleaning up someone's data, you can say no to all the ones you think's irrelevant. And what will happen is when you upload their document, this box will be unticked, but it'll still be there. So the doctor can still see, or you can still see, what you've cleaned up. And you can think, yep, I don't need to put that up. And the time taken now is when you talk to the patient and say, are you happy for all of this to go on your record? So this is when you have the conversation about, my 25 abortions that I might have had when I was, 20. And I say, look, that's not relevant anymore. I'm not in childbearing, so no, I don't want it to go up. And that's when you have those conversations saying, well, actually, might impact your gynae or whatever, So that's the sort of, if they say, I don't want depression to go up, you say, well, you should do. What if you get sick? And so then you just go, okay. And then this is what it's going to look like. So you have an opportunity to have a look at it. All of them do this except Communicare. So you have a look, and this is what the patient's going to see in their record. And this is the same in the consumer portal as the provider portal. This is what you'll see, and this is how it's done. So you've got a reason for each of the medicines. You've got your medical history and the date, so you know how old it is. And then you've got adverse reactions. And you can print it and give it to the patient, instead of the health summary that some of you are printing out now. And then you just go send. It's gone. And for that, how much money did we just get? Not bad, eh? So, any questions or anything about that?
As it's a patient-controlled record, if the provider puts that up in the portal, can the patient take it?
Yes. Okay, so say you didn't have the conversation with your patient and you put something up there, I don't know, something saying, I've got HIV or something, and you wouldn't, but just say, and I go home and I go, holy hell, why did they do that? And I delete it. When I go back to see you, you'll know that I've removed that document. So the author will know that the patient has taken it down, and that's when no one else will. So if I go to another practitioner, they won't know, but I'm not going to tell them that anyway, so what difference does it make? No. It just comes up in the column here. Document status. So this here, if I've removed one of these, it'll come up as redacted or something like that, I think. So that's what it means. And so it's really hidden. It's not actually removed. So say I removed a document and then I went and saw someone and they treated me unknowing what I'd already removed, but you as the nurse had put it up for me, and then there was a court case, it would go back and say, well, actually, you did upload something, I chose to remove it, and I was treated without that information. So if it's a medico-legal situation, it's still in the system. So it's really hidden as opposed to removed. Yeah. Okay, yeah, that's a good question, because that's been one of our challenges, because they've all got powers of attorney. But one of the things that nursing homes are starting to do, because there's some very good software at the moment, LeeCare and iCare are really committed to getting their nursing homes on board. As the part of the admission process, they're starting to get them registered with their relatives when they're there at the beginning of their stay in the homes. And it is difficult, and that's why, opt-out will be great for those people, because if you can send an event summary to a hospital or a shared health summary to a hospital and then get a discharge summary, it's a big win. John will take that on notice. There is a lot of work happening for those marginal groups in the opt-out sites.
So there is provision for someone else to, I guess, create a record for that person. So whilst most people either own their own record, make their own decisions, or have someone appointed, there is an otherwise appropriate person that we can recognise who can act on behalf of someone. So if it's someone, there might not be a legal piece of paperwork in place. In some cases, it literally could be the next door neighbour who helps someone out with everything that they can actually assist them. They can connect to a record and they could create a record for them. There is a process that they have to go through to kind of prove that, but it doesn't necessarily have to be supported by a piece of legal paperwork. It has to be done in a Medicare office, though.
Okay, there was a question here. Sorry, and then I'll come back.
Do you have any idea, in monetary terms, what the GP incentive payments are for this process?
I think it's up to 20,000 a quarter, isn't it, or 50,000 total? 12,500 a quarter.
Per GP or
Per practice. Yeah. Oh, so- Yeah, shared health summaries will stay there. You'll see all everything stays there in the document list, doesn't it? Yeah, so because one of the things you might want to look back on is someone's health record a year later, and you'll be able to go in, because every shared health summary you're updated, it'll still stay there. Yeah. Some of the GP software is doing that. It was one of our usability improvements, but they haven't all done it. But ZMed is about to come out, and what it's doing is looking at how many clinical documents have been added into a patient's record following their last visit to you, which is fantastic. So you're not going into empty records, because let's face it, most of you working in GPs know more about your patients than anyone else, and it's only when they go somewhere else that you want the information. The bang for the buck isn't for you, it's for when they go to hospital with your information. Yes, yeah, the author can take it down. Only the author. So if he goes to see a physio, for example, and the physio goes, "God, what sort of rubbish has he put in that?" he can't take it down. The author can, or the patient. Okay, so I just move along.
Is there anything that's considered essential that the patient mean, the big thing is medication. I know my GP is about blood shoppers, and they can remove medication.
Yeah, so a patient can remove, there's certain documents that can't be hidden or restricted access, but they can remove any document in a record. Yep.
Yeah, but just bear in mind they can't change anything. So if I put a prescription and I see it and I think, oh, I'll just double the dose of that endone, well, you know, I can't do that. So they're all like
That's just the same as you turning up as a person to GP clinic and not telling them.
Yeah.
So it's still your record.
Yeah, absolutely, exactly. I mean, how many people tell their doctors everything now? I mean, honestly.
So with dispensed medications,
Yeah.
will someone be able to hop in and remove that to them? Like, can I, if I have dispensed medication,
Yeah.
I can go and get into my record and take that off?
Yeah.
Okay.
Yeah. Exactly the same. So the only thing is, because you've got access to your PBS and your MBS, you can actually view your PBS. So really, you can't,
There's a whole lot of data about you already there.
that you can't actually remove. Unless, if you choose not to have it, that's a different story. But if you've got it there, it's there. Yeah, I can see your brain working. You're going to ask me about the 12-year-old who's been prescribed the pill or something. Okay.
So if I get into my Gov record, I can see, I don't have them, but I will. It's numbers up. So I can
They're chronic disease patients.
see the PBS, see the PBS record. So everything will be there.
Yeah.
You can remove that. Okay, so that's what I was wondering.
You can stop access to it. You can't actually take it away from PBS, can you?
I would.
Hey, through the mic, John. Okay, so I just... Sorry, you're talking. Okay, so just a couple more things, which we went through all of this. So this is what they look like. I think we saw that. These slide sets are really just so you can see these when you go home. And the thing is to have a team approach. So when you're looking at a shared health summary coming from a nominated provider, what we mean is a nominated care team. So you as nurses will qualify as part of the nominated provider. Now, someone asked me earlier if they could save a document and so then the GP could do the meds at the end if you wanted that to happen. I am getting a check on which software does. Some of the software does, but not all of it. But I think most of them do. And you can just save it in the notes and then they can upload it when they put their medications in. So clean up the data. This is just a checklist for practice managers, so not necessarily for you guys, but if anyone here wants to support the practice manager, these are the things you need to have. There's some nursing scenarios. Now this is the EPIP requirements. So this is the key. Now the only one that's changed is number 5. So those of you who are getting EPIP, the expectation is you were doing the first 4. And the 5th one previously was that you were registered and had conformance software. And now, guess what? We want you to use it. And as we talked about, you're right. As we talked about, the expectation is about 5 per GP equivalent. And I know initially what we're hoping, it's a very, very low bar. What we're hoping is that people realise how easy it is, becomes part of the workflow, and the patients who will benefit the most start getting one. And I guess that's what I want you to take away from here. Put your own up, put your doctors up, do all that to start with, but please start thinking about registering your patients who are going to benefit the most. Because what we want is improved health outcomes. Yes.
Is there a list of your own patients from your own? Can you see who you have registered? Like when you register
Okay, with what? Well, yeah, no, I don't know that they're doing that. In best practice, because at the moment best practice doesn't ping the HI service and then does PCHR exist, which all the other software does, although you saw Genie, you had to press a button. They're going to look at the appointment book and do a batch overnight. So when you come in and see your appointment book in the morning, you'll see who's got a My Health record and who hasn't. So then those that haven't, you can set about registering, and those that have, you can start looking at their records. We've got a data checklist. Some of you will have seen this. Have a look at it. Demographics, very important as we move towards an opt-out world. At the moment, we've got about an 86% match rate. That would be hopeless if everyone wanted a record. We need a 99% match rate. So if your patients haven't got IHIs and they come back, ask them to go to Medicare and check their data. Make sure you've got their right data. It might be a typo. They might have entered their birth of date incorrectly, or their name might be spelled incorrectly. So check what Medicare have, because Medicare at the moment can't actually tell you what the problem is. When you phone up and you say, John's doesn't match, they can't tell me that his name's Jonathan on their in their books, or his birth date's out by one date. Amazing. When I saw the data for the incorrect birth date, I had 2 insurance sort of things on my table at home. Both had wrong birth dates. I'd never even noticed before. But, it's a typo. They can do it over the phone. Yeah. All right, so counting your EPIP. This is what everyone wants to know. Some of you use PenCat, so you can count your uploads through PenCat. And this is how to do it. Medical Director has got a widget which was released last week that you can download. So if anyone is using Medical Director, this is what it's going to look like. That's what you do. I think these will be all available online. I've given them to someone to put out, and you can. And so that's see those counts there. So that's Medical Director. Best Practice is working on it. I'm not sure what these is going to look like or when it's going to be released, but it'll be pretty soon, because I think they all think they need to do it. Alrighty, so that ends my talk, and we've left a few minutes for questions.
Can I just clarify, because I missed the start, the opt-out, what's happening with opt-out?
Opt-out is being trialled in Queensland, far north Queensland, and the Nepean Blue Mountains. Yeah, and it's about the opt-out bit, not about the My Health record. My Health record is here to stay.
So everybody within that catchment, if they don't opt out, is in?
Yes, that's right.
Just be generated.
Yeah, exactly. A record will be generated with nothing in it
Yes, I was going to say.
in July, John? Mike.
Sorry. The opt-out period ends at the end of May. It's 27 May. People have to opt out before then. From 28 May through to 15 June, we create the records. Then there's a period of 4 weeks where people can come along and set controls or have a look at the record first, and then records are opened up for provider access from 15 July.
So people who haven't interacted in the process at all will have a record, but
Yeah,
nothing in it.
yeah.
And it can stay that way.
Yeah, and after the trial's finished, they keep their records. So the records aren't going to disappear for those people. And if people have opted out and then realise that their buddies are having such a good time with their records, they can opt back in. What? No, North Sydney doesn't have that.
Everybody's writing Australian.
Ah.
This seems slightly irrelevant because it's not happening. Yeah, so are we supposed to put Caucasian and what Indian?
I don't know. Is there a drop-down menu?
There's a drop-down menu, but everybody's just clicking Australian. But
I had a patient who actually asked me what should I put. Their father was Egyptian, their mother was English. And they said, well, what do I put? I grew up in Australia.
Eh? Yeah, I think it is in the registration though, isn't it? Oh, this is in your own GP software.
It's not in the My Health record system. So we have so you can the only thing that you can provide that flows through to My Health record or individuals self-declare is basically their Indigenous status. So nothing about any other ethnicity. It's literally just Indigenous status.
Okay, any more questions? Yep.
So is it a problem for us as if someone says yes, you can create a record for me, and you put in that they're HIV positive or whatever, or Hep C positive or whatever?
Because it's pulled out of your notes. Yeah.
Is there, can they come back and say something to you and just say, well, you put that up there and I've never told anybody else, you know?
Well, in your system, that should be confidential. So,
Should it be put on their record?
no, if you've marked it as confidential, it doesn't go up. But that's the discussion you have with the patient, saying, you've got a positive HIV status, would you like it up in your record? And some people will say, yeah, because if I ever go to hospital, it'll be handy. And just bear in mind, no one except somebody providing healthcare is going to see this.
I just think it's small country towns,
So
small country towns and that sort of thing.
They're already getting the facts. The receptionist already knows.
just to follow on from that question, I guess. If a person has a record, as part of the creation of that record, consent exists for documents to be added to it. You don't have to seek approval from an individual to add a document to that record, but you should use judgment to determine. So, if it's a prescription for Panadine or something, up it goes. You might not question it. If it's a prescription for something that's very specific to a condition or it's whatever, you might ask the question. So a patient can certainly ask for a document not to go up. If there's something that's sensitive, then absolutely have a discussion about whether that should or shouldn't be added to the record. But if it's material to an outcome somewhere else, then it may very well be something that should go up. But consent exists by virtue of the fact that a record is there. So you don't have to ask. It's more a judgment call.
Having said that, though, the expectation is that you do talk about what's in the shared health summary. There's a little thing down the bottom saying, I've talked to, the patient's given me consent. So it's a bit of an extra thing because it is their record. Just on that, the controls that people can have, there's two main controls, and one is a limited document access. So say I'd gone to hospital to have some plastic surgery. I might not want everybody to know about that, but so I limit that document. I put it up there, but there's a control on that document. And when I go to my GP, I tell him I've got a discharge summary that only he can see. And then I give him the access code, and so he can see that discharge summary of my hospitalisation, but no one else can see it. So that's a limited document access code. And then you can have an access code rack. Restricted access code, which you can limit organisations. So I might work at the local HealthScope hospital, and I might decide I don't want anyone in hospital ever having access to my record. So even if I go there in to have any care, I might go for an operation or something, I might still not want anyone to look at my record from that organisation. So I'd put a restricted access code against that particular HPIO. So does that make sense?
How's that done?
What?
How's it done?
When you go into My Health Record, there's a box when you set up your system that says access codes. It's right next to the alerts. So if you want to get an SMS or anything, you press on that button and set it up. And the same as your access codes are a little box. It's orange box, I think, isn't it? That you can go into and put your codes. Come on, you know this stuff, don't you, John? You built the bloody thing. Okay, so I'm excited. I hope you guys are, because it's afternoon tea time. We've got a booth and we are there. The government, Department of Health is beside us, and so there'll be someone there from either of us to help you answer questions. I'd strongly suggest you get hundreds of these and give to your patients and start getting them registered.
They're on their way.
They're on their way. Yeah, 100. If you need more, give us a call. We'll print thousands.